All right, today we are diving into the 2018 Molecular Testing Guideline for Lung Cancer. This was a really big deal, a landmark update that completely reshaped how we pick the right treatments for our patients. So, let's break down what you need to know about the current standard of care.
So let's get right to it. This is the central question, isn't it? The whole world of modern lung cancer therapy really boils down to this. We're past the days of a one-size-fits-all approach. Now it's all about precision. It's about looking at a patient's tumor, finding that specific genetic driver that's making it grow, and then hitting it with a targeted drug. These drugs, these tyrosine kinase inhibitors, can be incredibly effective. And these guidelines, well, they're our playbook for making sure we get it right.
So, here's how we're going to tackle this. First, we'll look back at the original 2013 foundation to see where we started. Then, we'll see how things evolved and jump into the big updates. The new genes we absolutely have to test for. Smarter ways to do that testing, what to do when patients relapse, and finally, the really cool stuff with liquid biopsies. Okay, to really get why the 2018 update was such a game changer, you've got to understand where we came from. The 2013 guideline was the first of its kind, and it really laid the groundwork for everything that followed. Think back to 2013. The message was pretty straightforward. If you had a patient with advanced lung adenocarcinoma, you were required to test for two things: EGFR mutations and ALK rearrangements. That was it. That was the standard. And the rules for how to test were specific too, like using a technique called FISH for ALK. This was our starting line. But of course, oncology moves at lightning speed. It only took a few years for a wave of new discoveries, new drugs, and new lab technologies to make it crystal clear that that original guideline needed a serious refresh. And you can really see the massive leap we took in that time. We went from this simple two-gene world in 2013 to a much more sophisticated, more powerful framework in 2018. The update wasn't just about adding more stuff. It fundamentally changed our whole approach.
So let's dig into the first huge change. You could argue this was the most important one: expanding the list of genes that we are now required to test for in every single patient.
And here's the new headliner, ROS1. The 2018 update came with a strong recommendation, which as guidelines speak for you absolutely must do this, that every patient with lung adenocarcinoma gets tested for ROS1. It officially joined EGFR and ALK as a must-test biomarker.
Now you might look at this number and think, wait a second, 2%? Why would we mandate testing for everybody for something that's only found in a tiny fraction of patients? It seems kind of inefficient, right?
Well, here is the powerful why. For that small 2% of patients who have that ROS1 rearrangement, the response to a targeted drug like crizotinib is over 70%. That is a phenomenal, life-altering number. So the lesson is clear. We test everyone to find that small group because for them, we can offer a truly transformative therapy.
Okay, so we're testing for more things. But the 2018 update also gave us a major upgrade in how we test. This made the whole process faster, cheaper, and frankly, a lot easier for labs everywhere.
A perfect example of this is ALK testing. The old way, FISH, was expensive, a real headache to perform, and sometimes tricky to interpret. The 2018 update said, you know what? There's a much simpler test called immunohistochemistry, or IHC, and it's just as good. This was a huge deal because IHC is way more common, it's cheaper, and it fits right into the normal workflow of almost any lab, a massive practical improvement. The guideline also officially embraced the technology that was a total game changer: next-generation sequencing, or NGS. You see, instead of testing for genes one by one, which wastes time and precious biopsy tissue, NGS lets us run a whole panel at once. We can look for EGFR, ALK, ROS1, and a bunch of others all in a single test. The guideline now clearly says this is the preferred way to go. And if you're going to run one of these bigger NGS panels, the guideline created a new category called should test genes. This includes targets like BRAF, MET, and RET. Now, these weren't mandatory to test for individually back then, but putting them on a panel is super important for finding patients who might be a match for a cutting-edge clinical trial, which just opens up even more doors for them. All right, the next big update gets into one of the toughest spots we find ourselves in clinically. What do you do when a patient who is doing great on a targeted therapy starts to get worse? The guideline now gives us a very clear roadmap. So, specifically for our patients with an EGFR mutation, we now have a standard protocol. When they progress, the move is to get another biopsy, either tissue or a liquid biopsy, and look for one specific thing: a resistance mutation called T790M. If you find it, that unlocks the next line of treatment with incredibly effective third-generation drugs like osimertinib. And here's a critical point. Our tests have to be really, really good, because that T790M mutation might only pop up in a small fraction of the tumor cells. So the guideline requires that labs use tests that are sensitive enough to find that mutation even if it's only in 5% of the cells. That's a high bar that older tests just couldn't clear.
And that whole conversation about rebiopsy leads us perfectly into our final, and maybe the most futuristic, update. We're talking about moving beyond the scalpel and into the world of cell-free DNA.
This is the famous liquid biopsy. We can literally find tiny bits of tumor DNA that are just floating around in a patient's bloodstream. It's a huge win when getting a traditional tissue biopsy is too risky or just not an option. But, and this is a really big but, you have to understand its limits. If the blood test is positive, you can trust it. But if it's negative, you can't be sure, because the tumor just might not be shedding enough DNA into the blood for the test to pick up.
And that brings us to the single most important rule to remember for liquid biopsies, taken straight from the guideline itself. If you do a blood test for a mutation, like T790M, and it comes back negative, you cannot stop there. You still have to try to get a tissue biopsy for testing. A negative in the blood does not mean it isn't in the tumor.
So there you have it. We've covered mandatory ROS1 testing, the big shift to NGS panels, having a clear plan for resistance, and this new world of liquid biopsies. As you go about your day, think about it. Which one of these changes will have the biggest impact on how you take care of your next patient? This guideline isn't just a document. It's a better, smarter playbook for precision medicine. Thanks for tuning in.